Hello, good evening, and thank you for attending tonight's presentation on lessons from the sleep docs. Allow myself to introduce myself. My name is Patrick Moday. I'm the moderator for this evening. Some housekeeping items: please turn off your cell phones or place them on mute. Questions will be asked after the end, and we'll take a quick intermission. The Miracle of Living Committee will take your questions that are written down, and I will pose the questions to the panel. If you would like a copy of tonight's presentation, make sure you leave your email address on the evaluation sheet. Also, you will be able to review the lecture again by next week, and a copy of the presentation will upload for you to download. Otherwise, please make sure you include on evaluation, and copy will be emailed to you. Thank you again for coming out tonight. Again, my name is Patrick. I'm a sleep tech here at Torrance Memorial. I help manage the sleep center. I've been doing this for about 20 years. Our next speaker is Dr. Khalid Eltawil. Dr. Eltawil earned his BA from the University of London and medical degree at Cairo University. He completed his residency and his pulmonary, critical care, and sleep fellowship at USC Medical Center in 2003. Dr. Eltawil is board certified in internal pulmonary, critical care, and sleep medicine. Dr. Eltawil is a pulmonary and critical care physician, also specializing in sleep medicine. He currently serves as medical director of the pulmonary services at Torrance Memorial and part of Torrance Memorial Physician Network. Dr. Eltawil is the director of the sleep lab and has practiced here in the community for over 20 years. Please welcome Dr. Eltawil.
Thank you, Patrick. Thank you, everyone, for having me here today. It's truly a pleasure to be here with you. I was asked. Any better? I was asked today to talk about sleep disorders, and as you can imagine, this is a really, really big subject. So I will try to touch on the common symptoms or problems that people come to the office to see us with. So there's a lot of complaints that people come to the office with, and probably the most common would be the wife can't sleep because her husband is snoring very loudly and has trouble breathing at night and usually really tired during the day. The husband sometimes complains of the same thing as well, where his wife does the same problem. So it goes both ways. We see patients who have leg pain at night and restless legs and can't fall asleep. See patients who are frequently watching the clock and can't fall asleep at night with insomnia. This lady here says her day starts backwards. She wakes up really tired and goes to sleep wide awake at night. So, and this is a common complaint we have. Usually it's a circadian rhythm problem, and I'll touch on that a little bit later on. And then we see people who just have abnormal activities at night, whether it's sleepwalking, sleep talking, sleep eating, or people who act out their dreams at night, abnormal nightmares and terrors and so forth. Probably the most common complaint we get is someone feeling tired all day long. So they come to the office saying, I just feel tired. And I usually take a moment to describe that there are two different sensations here. There's people who feel tired and people who feel sleepy, and it's not necessarily the same thing. Not everyone who is tired is sleepy. And the reason I mention that is that not all causes of feeling tired or fatigue are because of sleep issues. So for example, if you look at that list, and this is by no means a comprehensive list, you can see that one of the top causes is emotional distress, depression, and anxiety. If you're depressed, you will feel very tired all day long, not necessarily sleepy, not necessarily a sleep problem, but you will feel tired all day long. And in fact, people with depression frequently sleep all day long as well. So the medications you take for depression or anxiety can also make you feel sleepy. And in general, a lot of medications have side effects of fatigue. Medical conditions like anemia, heart problems, lung problems. I'm a pulmonologist as well, so I see patients with COPD and heart failure who are just having a hard time breathing, and just from this work of breathing, they feel tired. So not necessarily sleepy, but tired. If you don't eat well, you'll be tired. If you're in pain, you'll be tired. The medications you take for pain can make you tired. And way at the end here, you see sleep disturbances, they can make you tired as well. And that's what we'll try to focus on. The two biggest complaints we get are either sleep apnea or insomnia. Either you have sleep apnea or you just can't sleep at night. So I'll focus on those two a little bit in detail. So if you look at this picture here, this is sort of the face. Up here is the roof of the mouth, and this small thing that hangs down the back there, that's the uvula. You have the tongue sitting in the bottom there. So if with your mouth open, air kind of has to go through this small opening in the back. With the mouth closed, you notice that your tongue fits perfectly inside the mouth. We almost think of the mouth like a suction cup holding the tongue in place. You know, your tongue touches the teeth all around, the top and the bottom. So the tongue is held in place. If you ever have a cold or allergies or a sinus infection, then you open up your mouth to breathe. We all do that. With your mouth closed, air flows through the nose and into the lungs with no problems at all. People who have sleep apnea have a little bit of a different physiology there. For some reason or the other, they just can't get enough air going in through the nose, so they open up their mouth. By doing that, the roof of the mouth, the palate here, starts vibrating, and that's where the snoring sound comes from. And then with your mouth open, your tongue is no longer supported in place, so it kind of crowds the bottom there and blocks the back of the throat even more. So you're trying to breathe, but you're not moving enough air, or sometimes even the air stops altogether. That's what an apnea is. When that happens, your oxygen level drops, your CO2 level starts climbing, and then your brain starts thinking, I'm in trouble here, I'm not breathing. So you wake up, take a couple of deep breaths, and go back to sleep again. Most of the time, you're not even aware that that's happening. If someone is watching you, they would see snoring, and then a pause, and then a disturbed awakening. Usually it's a gasp or a snort or a cough in the night, and then you go back to snoring again. And the cycle just repeats over and over and over all night long. So you go through these cycles of arousals and then sleep, and then arousals and then sleep, and fluctuation in your oxygen level all night long. So sleep apnea will cause sleep fragmentation, where your sleep is disturbed all night, varying levels of oxygen level during the night, and that would cause the daytime sleepiness because you're just not getting a whole lot of rest out of your sleep. And more important than that is all the cardiovascular complications that happen from sleep apnea that we worry about. So if you look at sleep apnea, you get all the complications of someone who just didn't sleep well last night, and we've all experienced that. You know, you are not focusing well, memory losses, you wake up with headaches sometimes, you feel tired, you feel drowsy, and more important than that, like I said, is the cardiovascular issues. You can have arrhythmias, heart attacks, strokes. All these are complications associated with sleep apnea, and that's probably the main reason we treat sleep apnea. So this is our sleep center. It's located in the Macmillan building right behind here. This is what the sleep room looks like, pretty comfortable bed. So all you really need to do when you come in is, you know, you bring your jammies and a favorite book and a teddy bear if you want one, and you sleep pretty comfortably there. Usually there's one of the technicians sitting outside monitoring all the data on the monitors right outside the room. So you're never there by yourself. This is what you would have, a lot of sensors on the body. We usually put a lot of EEG electrodes, so similar to the electrodes that go on the chest for an EKG, but they go on the head, and those tell us if you're sleeping, how many times you woke up in the middle of the night, what stages of sleep you went into. We usually have some on the muscles that look at your muscle function during the nighttime. We check your heart all night long, as well as your oxygen level. And you sleep with all that. Most people say, how am I going to sleep with all this? And interestingly enough, most people do. Occasionally, we'd have one or two patients who can't sleep, but the majority of the patients end up sleeping. It'll not be the perfect night, but we get enough data most of the time. We also do home sleep studies. Actually, they're becoming more and more popular now, where we usually give you some sort of device to take home. And these devices can either sit on the chest, on the head, or on the wrist. Usually you attach them yourself. You're given instructions how to do so. You take it home and you sleep with it 1 or 2 nights. The data is collected on these devices and you bring it back to the office. We download these devices and then we look at the data together and discuss the next step. When we come to treatment of sleep apnea, there's a whole bunch of treatments out there. Positive airway pressure, which I will talk about in a second. We can use some dental devices as well that help with the treatment of sleep apnea, and there are some surgical options that can be considered. These are the main treatments. There are some other treatments out there as well, but these are the main treatments. So as far as positive airway pressure goes, right now when we breathe, we all breathe by negative pressure. So you create a vacuum in your chest and air rushes in, and then you just let it go and air comes out. So CPAP is short for continuous positive airway pressure. So think, if you will, if you get a balloon and you blow air into the balloon, it kind of holds itself up. That's what CPAP does. It's positive pressure keeping the tissues away. So if you see what the CPAP is doing, it's just keeping a positive pressure in the back here, keeping the tissues away from the back of the throat so you breathe more comfortably. So if you look at the picture down here, you'll notice before CPAP, there's blockage down here. After you add the CPAP, then that pathway is open. These two are probably the 2 commonest CPAP machines on the market. They're made by ResMed and Philips, and there's a couple of other manufacturers that make others that are not as popular, but work as well. And then you have what we call travel CPAP machines. If you feel that the base ones are too big, there are ones that fit in the palm of your hand and you can just travel with them very easily. Most people just travel with their regular CPAP machines. Some people like the smaller units. And then masks. This is probably a big one. Everyone imagines Darth Vader with a big mask on your face when you go to sleep, but that's not really the case. There are so many masks on the market, so many manufacturers, so many of them out there. Nasal pillows are very popular these days. What these are just 2 small prongs in the nostril, usually held by some sort of attachment to the head, usually a rubber band of some sort, and it just stays in place. It's very comfortable, easy to take on, put on and take off. This is like a cradle that sits under the nose, also very comfortable, very soft. We have the nasal mask that fits around the nose. This one is a full face mask around the nose and mouth, and we do have ones that fit over the whole face. And there's no one that's better than the other. It's really a matter of personal preference. Some people like the smaller ones, some people like the bigger ones. It depends on your face and what you prefer. They all work really well and they're all interchangeable, and people generally start with one and a year or 2 later, they've already settled on the one they like and they just persist with that. The next step for treatment is dental devices. Those are usually recommended for people who have mild to moderate sleep apnea. Doesn't really work that well for severe sleep apnea, although in some people with severe apnea it works. These are devices that sit on the teeth, and they have some sort of mechanism on them where the mandible is pulled forward. So when they fit on the top and the bottom teeth, and when you close your mouth, the mandible just moves forward. And by doing that, it moves the whole mandible with the base of the tongue and so forth forward, so it opens up the pathway in the back there. Usually a dentist would make them for you. You would go to see a dentist, he'd make a print of your teeth and manufacture it custom to your teeth. And you use it for about a week or 2 until you get used to it. And then afterwards you would go there and they would make adjustments to it and slowly move the teeth forward over a period of a few weeks. And then we have surgical options. Dr. Gertel will be touching on those, so I will leave that to him. So switching gears a little bit, insomnia. Insomnia is probably something that we've all experienced. It's a very common condition, and every now and then we all have a bad night, we can't sleep. Sometimes it lasts for a few weeks, sometimes it lasts for a few months. Usually I see the ones that last for many years. So what we call the chronic insomnia. But essentially what happens is you're either watching the clock all night long, playing on the phone all night long, watching TV, or some people just work in bed and they can't sleep and they develop habits that they keep doing every night, and that's usually when they come to see us. There are many causes for insomnia. Some of them are sleep-related and some are not. So the sleep-related ones, this is just examples. Circadian rhythm, if you remember that lady who had her day backwards. So circadian rhythm essentially is a condition where there is a clock in our brain that tells us when to do everything we do. It governs all our bodily functions. All our organs are governed by that clock. So it tells us when to go to sleep and when to wake up. If you go to sleep before it's time to go to sleep, you will not be able to sleep. And if you wake up before it's time to wake up, again, you'll feel tired. You'll not be happy with that. And that's why things like jet lag happens. You travel to the East Coast or Europe or a different time zone, and you're supposed to go to sleep with society over there, but you can't because it's a different time zone. Usually it's short-lived, and usually if you work on your timings, you're usually able to correct for that. Sleep hygiene is sort of a vague term that we describe what you do in the course of the day that affects your sleep. So the easiest way to understand that is at any given moment, whether day or night, we have certain factors that want to wake you up and certain factors that want to put you to sleep. And it's the balance between those two factors that decide whether you're awake or asleep. So for example, let's say it's 8 o'clock in the morning, your internal clock tells you it's time to wake up. You have your cup of coffee that's waking you up. The sun is shining, it's waking you up. Someone talking to you, that's waking you up. So all these are wake promoting factors, but at the same time, you didn't sleep well last night, so you're really tired, but it's not enough to overcome these. So you stay awake. At night, it's the same thing. You're in your bed, your internal clock is telling you time to sleep, your room is nice and warm and comfortable, and all these are factors putting you to sleep. But let's say, my son is watching TV outside, for example, and I can hear that noise, but it's not enough to keep me up, so I fall asleep. Now, this balance, as long as it's like that, it's perfect, your sleep and wake pattern remains okay. But we do things that disrupt this pattern. So for example, let us say nighttime, you're ready to go to sleep, but you've just had a whole pot of coffee, or you have friends over and you're talking. All these things are waking you up. So even though we do have factors making you go to sleep, but all these social interactions is waking you up so you don't sleep. The same thing in the morning, you're supposed to be awake, but you haven't slept in a couple of days. Well, after 2 or 3 days of not sleeping, you will be really tired, and that can put you to sleep instead. So it's the balance of these two factors over the course of the day at different times of the day that determines whether you're awake or asleep. Restless leg is another common one that we see, and it's a very odd sensation that people have as they go to sleep at night. Some people describe it as a creepy crawly sensation in their legs. Some people describe pain in their legs. Some are just can't get comfortable in bed. And it only happens when you go to sleep at night. So all day long you feel fine, your legs are okay, and then you get into bed and they start acting up. Or periods of where you're just sitting passive, like in a movie theater or on a plane, it becomes really torturous. And usually the only thing that relieves it is if you get up and walk around for a little bit, then it calms down, you get back into bed, and then it starts up again. We do have treatment for that and things we can give for that, but that's a common cause of insomnia that we see as well. And then we have other causes that are not sleep related. As you can see on the top of the list is anxiety, depression, and emotional distress. It is estimated that about 35% of people who have insomnia have underlying depression or anxiety. In fact, it's extremely difficult to treat insomnia as long as you feel depressed or anxious. It's very difficult to do so. And usually, I would not even attempt to treat insomnia until the depression and anxiety are controlled. And frequently, I seek the aid of fellow psychiatrists or psychologists to help with this treatment. And then after that, we can focus on the insomnia. Many times, just treating these conditions alone, the sleep just falls in place and becomes back to normal. Pain and discomfort also causes insomnia. If you have back pain, joint pains, knee pain, you will not be able to fall asleep. Shortness of breath is a common one. Again, I'm a pulmonologist. I see that in my office frequently. People have COPD and they're just working hard to breathe, and they have a hard time falling asleep because of that. And medications, caffeine, nicotine, and so forth. Caffeine is interesting. I'm sure there's people here in the room which will tell me, I have my cup of coffee at night and I still can fall asleep. I'm sure a lot of people do that. I used to do that myself. And that comes back to the sleep hygiene, where there's even though you're having this coffee at night to wake you up, but it's not doing so because there are other things putting you to sleep as well. But having a lot of coffee at night, or some medications are stimulants, and if you take them at the wrong time of the day, they will cause insomnia. But we divide insomnia in general into either short-term or long-term insomnia. Short-term insomnia is usually less than 3 months duration, and it's usually related to some sort of stressor. Something happened in your life that made it difficult to fall asleep. You got a new job, a travel, loss of a loved one, got a medical diagnosis, some sort of stressor happened that is preventing you to fall asleep. Usually resolves when this stressor resolves. So once the stressor is gone, you start falling asleep on your own. Many times we don't even treat it, we leave it alone, things will improve on their own. If it becomes a large burden on your life, then we can consider adding short-term treatment for that period of time. Long-term insomnia is different, and usually the way I think about it is that some people are hardwired or have an underlying predisposition for long-term or chronic insomnia. And usually it lasts more than a month and can last for years and years, sometimes even decades. And usually have some sort of underlying factor that predisposes you to insomnia, whether it's a mental health problem or a medical condition or some neurological disorders. You're ready to have insomnia even though you don't have it yet. So this is sort of a model of how to understand why chronic insomnia occurs. So as I mentioned, some people are just predisposed to having the insomnia, but they did not meet the insomnia threshold yet, so they're sleeping fine. And then a stressor occurs, and this is what we call a precipitating factor, that this stressor causes the insomnia. Something happens, like I said, a new job or an illness or something that made you unable to fall asleep that night. And so you cross over that threshold for insomnia and all of a sudden you can't sleep. As time progresses, a few weeks pass by, then this factor is not as strong anymore. So you've been at your job for the last 2 or 3 weeks, is not as stressful as you thought it would be, but it's still bothering you a little. But then you start developing certain habits to help yourself with this job. So for example, your job was very stressful, so to stay awake, you started drinking more coffee, for example, or you started spending awake times at night, preparing for the day at your job. You develop habits to help you cope with the insomnia that has started to happen, and these habits are on top of the predisposing factor that you had. And then as time progresses, even a few more weeks pass by, the predisposing factor, even though is still there, but is no longer an issue. You've been at the job for months now, you know exactly what to do, but you still drink that pot of coffee every day. You still watch TV at night. You still work in bed every night. So your habits are what are keeping you above that insomnia threshold, and that's what continues with the insomnia for years and years and years because you maintain those habits. Sometimes they become very hard to break. So when we think about treatment, there are many different ways to address insomnia. If you can find an underlying cause and treat it, well, perfect. That would, like, if you have chronic pain and you treat the pain, well, the insomnia will go away. That is not always the case, but sometimes we get lucky. There are some medications that we give. Some are over the counter. Does anybody know what the commonest used over the counter medication for insomnia is? Alcohol, exactly. Yes. Yeah, it's very commonly used. A lot of people use it to help go to sleep, but unfortunately, even though it is sedating, it is not does not result into restful sleep. It actually ruins it makes the quality of the sleep worse. So you end up feeling worse the next day. But yes, Benadryl or antihistaminics are commonly used. Melatonin, valerian root, and so forth are commonly used over the counter. We use some prescription medications. The benzos are the ones that are frequently used for anxiety and so forth. And then the non-benzos, which are commonly known as the Ativan, the Ambien, the Lunesta, Sonata, and so forth. These are prescription medications. I am not a big fan of prescription medications for insomnia, but sometimes we do give them if we need to. And then we have antidepressants that we also use frequently for insomnia. They work in two ways. As I mentioned before, that a lot of people with insomnia have depression. So if you treat the depression, the insomnia goes away. But antidepressants in themselves, some of them have sedating qualities. So many times we prescribe antidepressants for the insomnia for both conditions. We try to educate about sleep hygiene, and that is somehow or the other talking about the factors that promote sleep and trying to discourage the factors that are detrimental to sleep, and work on a changing the habits that you have during the course of the day to help with getting better sleep. There is an entity called cognitive behavioral therapy, and what that is trying to manipulate and adjust your sleep timing and conditions. So we try to figure out what your sleep pattern is and try to adjust that pattern, and that helps to reduce the anxiety that happens as you're trying to fall asleep or in bed. The problem with this is that it's sometimes you feel a little bit worse before you get better, and people have a hard time adhering to the program. But when it is successful, if you do adhere to the program, it usually works pretty well. If you can find methods to relax, that helps quite a lot as well. And then mindfulness is sort of another way to think about it. It's if you can purposely be aware of the present moment, particularly during the day, like you're aware of your breathing, your physical sensations, your thoughts, your feelings, and if you can have all this information being processed during the daytime, generally leads to this process being deactivated at night, and then at night you're able to fall asleep a little bit easier. It helps remove the negative thinking that happens at night and the rumination and so forth. So rules to have a good night's sleep. Rule number 1, select a standard wake-up time. This is extremely important. And this is, you should maintain that wake-up time, whether it's a weekday or a weekend, whether you had a good night's sleep or a bad night's sleep, or if you slept at all at night. And I usually add to that if you can wake up and then have some light exposure in the morning. That way you are setting that internal clock to a certain wake-up time every morning, and it becomes persistent, and you become used to it after a while. Use the bed only for sleeping. This is also very important. So if you remember Pavlov's experiment from when we were kids, Pavlov was a scientist. He got a dog, and he would give the dog some food and then ring a bell. And he did that many days in a row. And then after a while, he would give the dog he would just ring the bell, and the dog would start salivating, expecting the food. We call that conditioning. So the human brain works the same way. One of the strongest stimuli to go to sleep is the act of actually getting into bed. So for someone who does not have insomnia, they could be wide awake, and the moment they get into bed, they start feeling a little drowsy just because they got into bed. People who have insomnia report a totally different experience. They say, I could be falling asleep on the couch, and the moment I get into bed, it's like someone turned a switch on. I'm wide awake. And that's because of this conditioning issue. So if you watch a lot of TV in bed, if you read in bed, if you work in bed or eat in bed, then the brain gets confused. Why am I here? Am I here to sleep, or am I here to stay awake? What exactly are you expecting me to do? And frequently, if you are able to fall asleep and then you wake up in the middle of the night, the whole process starts over again. Now I'm awake. How am I going to fall asleep now? I need my TV, I need the food, I need the computer, I need all these things to help me go back to sleep again. So trying to keep the bed only for sleeping helps a lot with that. And the same thing with getting up when you can't sleep. So if you get up in the middle of the night, give yourself 10, 15 minutes. If you can't fall asleep, you get up, watch TV somewhere else, read somewhere else, and then when you start feeling sleepy, then you come back to bed again and try to sleep again. Eventually, this will stop happening, and eventually the brain gets trained enough to say that I'm in bed, I'm here to sleep. Do not worry and plan, etc. in bed. That's very difficult to do, because the moment we get in bed, our brain starts working. And that's when I tell people, if you can sort of schedule some time earlier in the day before you go to sleep for the worrying and the planning, and get all that out of your mind. And then when you come to bed, you stop doing that. Or if you find yourself worrying and planning in bed, just get up, go sit somewhere else for 15, 20 minutes, get all those thoughts out of your head, and then come back to sleep when you're ready. Avoid daytime napping. That is somewhat controversial. If you look at the literature coming out of Europe, daytime napping is very important. Everyone takes their afternoon siesta. And I don't have a problem with that for as long as it doesn't interfere with your sleep at night. So if you tell me I sleep great at night, but I like my hours rest in the afternoon, there's nothing wrong with that. But if you fall asleep in the afternoon for 1 or 2 hours and then you have a hard time sleeping at night, avoiding the daytime napping actually helps quite a bit. The moment we wake up in the morning, there is actually a neurotransmitter that starts accumulating in our bodies. And the longer you're awake, the higher the value of this neurotransmitter, and that helps you go to sleep at night. So if you take a nap in the middle of the day, then the levels of this neurotransmitters are suppressed and you don't sleep that well. And then go to bed only when sleepy. This is also a very important one. So sometimes we go to bed because we're done with the day. There's nothing good to watch on TV. I'm done talking to all my friends. I'm done with all the housework. There's nothing else to do. I'm going to go to bed. The problem with doing that is that you're not ready to sleep yet, so you're going to spend a lot of awake time in bed, and by doing so, you'll get frustrated, and then the whole cycle for insomnia starts. So if you're able to stay awake until you're really feeling sleepy, then you'll prevent all that from happening. Limiting caffeine, alcohol, and so forth is important. Avoid steady use of sleeping pills. Now, that also sounds odd because here you are trying to go to sleep at night and I'm telling you not to take sleeping pills, but it's the steady use of sleeping pills that's important. So when we all go to sleep, we kind of have a checklist in our mind of things that we need to do before we sleep. So I need to put my pajamas on, I need to turn the light off, I need to brush my teeth, I need to take my sleeping pill. As long as all these are checked off, then I can sleep. If one is missing, I didn't take my sleeping pill, you will have a hard time falling asleep. So if you habitually take a sleeping pill every night, you will have a hard time falling asleep without it. Scheduling a downtime is important. Keeping the room dark and cool, a little bit on the cooler side is important as well. And sometimes you have a hard time falling asleep because of hunger, so a small snack can be helpful. That's all I have for you, and I'll take questions later. Thank you.
Thank you, Dr. Eltawil. Our next speaker is Dr. Alexander Gertel. He's a board-certified ear, nose, and throat surgeon with the Torrance Memorial Physician Network. He completed his undergraduate studies at USC, then went on to medical school at the Medical College of Wisconsin in Milwaukee. He moved further east to do his ENT residency training at the University of Connecticut, where he was awarded the Resident Teaching Award as a chief resident by his peers. He has now returned to the West Coast and has been in practice at Torrance Memorial for over a little over a year. He has an interest and expertise in all aspects of ear, nose, and throat, including the diagnosis and management of vertigo. Please welcome Dr. Gertel.
All right, good evening, everybody. Again, I'm Dr. Gertel, one of the ear, nose, and throat surgeons here at Torrance Memorial Physician Network. And I'm going to be focusing mostly, really all on sleep apnea tonight. So, as Dr. Eltawil touched on, the first line gold standard treatment for sleep apnea is CPAP, this continuous positive airway pressure, because there's a lot of advantages to it. It's non-invasive, so it's not a surgical procedure. There's really no risk at all wearing or using it. It can be extremely effective in curing sleep apnea, so OSA, obstructive sleep apnea, for people who do tolerate it. And the modern machines are very quiet, and so a lot of advantages. But the problem is that a large percentage of people just don't tolerate their CPAP for various reasons. It can be because they feel claustrophobic when they're wearing a mask, or the mask is uncomfortable, or it doesn't fit right, or it's too tight, or it's too loose, or you roll over in bed and it might fall off, or you just subconsciously take your mask off. You wake up and somehow it's off. It potentially could be delivering really high pressure settings, and that could be uncomfortable, and that can make the nose and the mouth really dry, which can also be uncomfortable. So what options are there for people who don't tolerate CPAP? And so that brings us to, why would you even see an ENT for sleep apnea? And the reason is for the surgical management of sleep apnea. So sleep apnea is complicated. And as we just learned, that what exactly is sleep apnea? So it's where something in the throat is falling backward into the airway while we're sleeping, and that blocks our airflow. So air is not going in or out. And the reason why this might happen is different in everybody. So there are different areas of our throat that could be causing the sleep apnea. We might be having airway obstruction because our tonsils are really big and that's blocking the airway, or the uvula is large, or you've got a long, soft or floppy, soft palate, roof of the mouth. Sometimes it's because you have a large tongue and that's falling back and blocking the airway. And one of the more common things is as we gain a little bit of weight, we get a lot more soft tissue, especially in the neck and throat. And when we go to sleep, we lose all of that good muscle tone, and all that tissue just falls back into our airway, flops backward, and that also causes obstruction. And so this is just an example of some of the things that could cause obstruction. So if you imagine just someone who has really small tonsils, really not going to have any real issue maybe with sleep apnea if their airway looks like this. Compare that to somebody who has really big tonsils, so that might be very problematic. But there are other things that can also cause the obstruction. That might be like just a very large tongue. So someone with a small tongue, and you can really see the back of the throat really well, probably not going to have a huge issue with sleep apnea. But if you imagine someone with this type of tongue, very large, so that it's not surprising when that kind of falls backward as we sleep, causing the sleep apnea. So there are many surgeries that have been developed for sleep apnea to address all the different levels of the airway. But when it comes to sleep surgery, one size does not fit all. And that is because everybody's different, and everybody's sleep apnea and obstruction might be coming from a different part of their airway. Another part of sleep surgery is that oftentimes they're fairly painful recoveries. And even though there are a lot of different surgeries, they might only be successful really in like the ideal candidate. So for example, if you can clearly identify like where is that obstruction coming from? Is it the tonsils? Is it the tongue? Is it the uvula? Is it any of the structures that can be falling to the airway causing obstruction? So if you have a clear source of obstruction, that's a good start. But also someone who has a lower body mass index, lower weight, will also have a lot more success with surgery. And that is because we can correct big tonsils. We might be able to correct, a big tongue or a big uvula, but what we really cannot correct with any air or sleep surgery is all that soft tissue that will fall because of elevated body weight that falls into the back of the throat. So really these surgeries, the classic surgeries are really successful in these ideal candidates. And sometimes you do one thing and it doesn't work that well, and you might have to do another surgery. And so sometimes multiple surgeries or multiple procedures are required. So these are just an example of some of the sleep surgeries that have been developed over the years. The most famous or most common one, which we'll talk a little bit more about soon, is this one called the UPPP, or the uvulopalato-pharyngoplasty, that involves removing the tonsils, removing the uvula, a little strip of soft palate, and really kind of opening up the throat airway. There are other surgeries that involve rearranging some of the throat muscles to make more room. So this side compared to this side. This is a picture of, so at the back of the tongue, we have a lot of like tonsil tissue, and in some people, there's a lot of tissue there. And so there are ways, so this is like the very back of the tongue with all that tonsil tissue. This is what's called the epiglottis, and our airway would be here. So if you can imagine when going to sleep is all this stuff falling backwards, blocking the throat. So there are ways that we can shrink that down with laser or with a coblator or other instrumentation to get that tissue out of the way. This is hyoid suspension, the bone at the very top of the throat where a lot of the throat muscles and tongue muscles attach to. So you can actually pull that forward and suspend it from the jaw. It sounds kind of barbaric. It kind of is. And similarly, some other similar barbaric sounding surgeries are, you can actually kind of make cuts in the jaw and move the chin forward. And kind of the biggest thing would be this thing called maxillomandibular advancement, where you actually make cuts in the jaw and in the lower and upper jaw and actually pull everything forward. With the idea, all these surgeries, the idea is that you're pulling everything forward and trying to get it out of the way of the airway. So the most famous, the most common, still done very frequently, is and maybe one of the more straightforward surgeries is called this UPPP, uvulopalato-pharyngoplasty. It's a long word, but again, the idea is this is what throats normally look like. So you've got two tonsils on the side, you have this uvula in the middle. This is the soft palate or the roof of the mouth. And what you can do is remove all these things and kind of put some sutures or stitch the tissue together. And it'll heal in this way, but you can see that that gives you a lot more room to breathe. But just as an example of how you really have to have the perfect patient, you have to be the perfect patient for these things to have success. So that in order to really evaluate, are you the right candidate for this type of thing? So that involves coming into the office, having a good exam, and having someone take a good look at the tonsils, all these areas. And one of the ways that we can try to predict success so that we can go into the surgery, hoping that we're going to have a high success rate, is there are these various staging and grading systems for really evaluating the throat in general for sleep apnea, but also for this particular surgery. We use something called the Friedman clinical staging, and this involves taking into account the size of the tongue, how big are the tonsils, what is the body mass, and there are different stages. The person who's going to have the best success will have really big tonsils, a tiny tongue, and be low body weight. Because if you just remove the tonsils and some of the tissue around it, you can imagine there's going to be a lot more room and have a lot more success. Compare that to the patient who's got a huge tongue and maybe tiny tonsils, and even if they are not that heavy, so that tongue is still always going to be in the way, and so you might not have that much success with this surgery. And just to demonstrate that, there was a study that showed that in these perfect patients, the success rate is about 80%. I mean, look how quickly it drops, though. I mean, for a patient with small tonsils, really big tongue, and it will be even less for someone who's really overweight. I mean, the success rate is not great at all. And why would you go through that big surgery and all that painful recovery? I mean, it's removing your tonsils. It's a terrible thing to go through as an adult, and still really have that really low success rate. So this just demonstrates how there's a lot of evaluation that goes into predicting how well you're going to be, how well you might do with one of these surgeries. What about nasal surgery? So some people have what's called a deviated septum. That means this middle part of the nose, which is made out of bone and cartilage. So a lot of people are just born this way, but sometimes it can be from like a breaking your nose or a nasal trauma. So this means that the septum is bent over or curved over to one side, and so there's less room to breathe through the nose. That's what a deviated septum would do. These structures are called the turbinates, and sometimes they can be really swollen, and those can be blocking the airway. And some people have an issue where when they breathe in, their nose collapses down. This is kind of the idea, this is what Breathe Right nasal strips would cure. They prevent the nose from collapsing. So there are various procedures where you can put little implants in, or even use your own body's cartilage to give yourself some just more stiffness of the cartilage so your nose doesn't collapse. But the thing about nasal surgery is that nasal surgery does not cure sleep apnea, because sleep apnea is not occurring from any obstruction in the nose. It's all down in the throat. However, there may be a role for it to play in the treatment of sleep apnea, and that is to help with CPAP tolerance. So if somebody is not doing well with their CPAP mask because their nose is blocked and they can't get that pressure through and it's really uncomfortable, well, doing something to fix the nose and to open up the nose better might make it a lot easier to tolerate CPAP. And these surgeries are a lot easier to go through than all of the throat surgeries. And so if someone likes CPAP, they want to keep using it, but they're still uncomfortable and there is a problem with the nose, these can really help. So that brings us to maybe one of the more exciting and newer treatments for obstructive sleep apnea, and that is the Inspire hypoglossal nerve stimulator device. So this is a surgically implanted device that is indicated for treatment of sleep apnea. The idea is that it relieves the obstruction, and we'll talk about how that works. This was approved by the FDA in 2014. Since then, there have been more than 30,000 implants performed in this country. So it's really has a good track record, and it's done as a safe outpatient procedure. It is done under general anesthesia, but you go home the same day. You can be back to normal activity within a week or so. And the idea behind this is that what you should be able to do is you press a button, you go to sleep naturally, and the device does the work. The device relieves that obstruction. And again, we'll talk about how that works, but there's no mask, there's no hose, there's no machine. It is just an implant inside you. It has a remote control that you use to turn it on, and it's really can be a lot more natural way of sleeping. Yeah. So how does it work? So the tongue is controlled by a nerve called the hypoglossal nerve. This is one of our major cranial nerves. And this nerve has branches that tell the tongue to protrude outward. There are other branches that tell the tongue to control the tongue and cause it to go back into the mouth. And so the idea is that if we can stimulate this nerve and target those branches that cause the tongue to protrude outward, then the tongue will go out and will draw out all that soft tissue, like a big tongue or all that soft tissue in the throat. So it'll stimulate it to basically come out of the throat a little bit and relieve that obstruction. So this implant, there are three parts. There's a stimulation lead. This is a lead that wraps around that nerve in the neck. That connects to a neurostimulator and battery in the chest, and this looks like a pacemaker. That neurostimulator delivers that stimulus to the nerve, causing the tongue to protrude outward and to relieve the obstruction. And there's also a sensing lead that senses whenever we take a breath. So the way it works is that we go off to sleep. Whenever we take a breath in, that sensing lead senses the breath. It tells the neurostimulator that we're breathing in. This sends a gentle impulse up to the electrode that's around the nerve, delivers that impulse to the nerve. That causes our tongue to protrude outward slightly, thereby relieving the obstruction in the back of our throat. Another benefit of this is that not only does it cause the tongue to come forward and relieve the obstruction, but it gives our throats a little bit of that muscle. It gives it back some of that. It sort of tightens up the throat, so it gives it that tone. So it gives it that tone back to also help to eliminate the obstruction. So the surgery, so it's done through two small incisions. So there's an incision on the neck, and there's also an incision usually done on the right side of the chest, at the top of the chest. The implant in the chest sits right over the pec muscle under the skin, and again done under general anesthesia, but two incisions. Again, we talked about the fast recovery. Usually it's really not a very painful thing to get through, just usually over-the-counter pain medication. You can return to activity within a few days. This does need a battery change at some point. So there's about 11-year battery life of this device. And so if you would need to change the battery, so that would be another surgery to go through that same incision on the chest to replace the neurostimulator device. You only have to replace this part. So this part you leave alone forever. This part, just this part you would change. And is it MRI compatible? So the answer is yes, it is. There's actually a couple of different types of MRIs. One, and it really depends on the strength of the magnet that is used. So for the sort of standard, we call it 1.5 Tesla magnet. So the device is compatible. There is another MRI, mainly might be more in academic centers that are 3 Tesla, so much stronger. It's not compatible with those, but for most MRIs, it is compatible with. So, even though it's an exciting new therapy, there are still some criteria. So not everybody, unfortunately, is a candidate for this. But these are some of the eligibility criteria. So you have to be an adult, 18 years of age or older. There is a body weight or body mass requirement here. So for PPO insurance, HMO insurance, your body weight or body mass index, BMI, has to be below 32. Medicare, a little bit more lenient, less than 35. You have to have either moderate to severe sleep apnea. This is measured, the way that we measure sleep apnea is by this metric called AHI, or apnea hypopnea index, which basically means how many obstructive events are you having per hour. And so moderate to severe is in this category, about 15 to 65 obstructive events per hour. If somebody only has mild sleep apnea, you are not a candidate for this. There's another more rare condition called central sleep apnea. That means that your body, this is more of a neurological condition where you just stop breathing. There's no obstruction. Your brain you stop breathing for a while. So unfortunately, this device does not treat that. But again, that is much less common. You do have to have a sleep study that's less than 2 years old. So if it's been like 5 years since your last sleep study, you would have to repeat it just so we get the most updated information and make sure that you fully meet these criteria. CPAP failure or inability to tolerate CPAP. This is for any reason. I mean, it could be just, it falls off all the time. It's super uncomfortable. You feel claustrophobic. So a very broad definition of what does it mean, CPAP intolerance. And then appropriate airway anatomy. We're going to talk about that soon and how we determine that. This is just an update. So just last month, the FDA actually expanded the indications for Inspire. So it's now allowing, for instead of a limit BMI 32, so now it can, patients who have a BMI of 40 or below could be candidates. And the number of events per hour, it was capped at 65. Now you can have up to 100 events per hour and still be a candidate. The caveat to that is that just because the FDA approves something doesn't mean that the insurance companies are going to follow right away. So it might take there might be some lag time before the insurance companies incorporate these new updates into into what they agree to cover. So, all right, so back to determining the appropriate airway anatomy. So this is done through something called a drug-induced sleep endoscopy, or just a sleep endoscopy. So this is a quick procedure that is done in the operating room. So it is something that has to be done in the operating room, another procedure before we can fully determine it if you're a candidate. And you can think of this like a colonoscopy, but there's no prep and we're going from the front. So it's a lot easier to go through. It's a quick procedure. I just did one today. It took me 5 minutes to do this. But the idea is that we give you a little anesthesia, kind of simulate sleep, get you snoring, and then while you're in that sleep-like state, we put a little telescope through the nose and examine all levels of the airway. And one of the requirements for being a candidate for Inspire is that we really, the main place that we're looking at is the very back of the nose, or the top of that soft palate, because they found that in some people with certain anatomy, the device just doesn't work well. So this video is showing, this is the uvula down here, but basically what we're going to be seeing is, so this is at the back, this is the nose, this is the back wall of the throat, this is the front, this is that uvula and the soft palate. So if you just have, this is kind of a normal anatomy, is that when you breathe in and when you're sleeping, you might get a little bit of front and back collapsing. Sometimes there can be some side to side. That's great. That's compatible with Inspire. However, if you can see what's going on with this patient, it's almost like a circle. It's like we call it concentric collapse. So it's collapsing from every direction. And they've just found that patients with this anatomy just don't do well. They don't respond well to the device. And so this is still a requirement before we can fully determine if you're a candidate, is making sure that you don't have this and have this. So, but that's done with this short procedure. So let's say you go through, you're a candidate, we end up doing the surgery. So what happens next? So about 4 to 6 weeks after surgery, you go into the office, and that's the first time that we actually activate the device. So after having the actual surgery, you don't use it for 4 to 6 weeks, let things heal, let the incisions heal, and then we go into the office and we activate it. So this is done in the office. You can basically put a little device over where the implant is and turn it on, make sure that it's working, and start and make those initial settings. The initial settings that we usually that we're setting are basically the amplitude of the stimulus, so the strength of the stimulus, and also the latency. What that means is when you actually push the button to start it at night, you can adjust how long does it take for it to actually start working, because you want to leave yourself time to get off to sleep. Maybe you want to brush your teeth and get into bed and then get off to sleep. You really don't want it to start working right away, because then every time you take a breath, your tongue is going to be kind of flicking out a little bit, and that's that probably would prevent you from going to sleep. So you can set the interval. It could be 15 minutes, half an hour, 45 minutes, an hour, whatever it is, but we set like that initial latency for when it starts to work. And then you go off and you use it for a couple of weeks. The remote control, it records, how long are you using it for? What was the level of the stimulus that you got? And actually at home, so there are some things that a patient can control, some things they can't. The things that you can control are, number one, turning it on and off. And the other thing is that when we do set the strength of the stimulus, we always, there's a range. So there's like a lower level of stimulus and then an upper range. And so you can, within that range, you can make adjustments. You cannot go outside higher or lower. That is only done in the office. But but basically you can play with that the first couple of weeks, see how you do with it, come back into the office, kind of fine tune things, review the usage, adjust how strong you might need it. You can adjust something called pulse width and the rate. Basically, there are different ways, patterns of the stimulus that you get that can be adjusted for comfort and efficacy. You can adjust how long it takes for it to start after you press the start button. And then finally, about 3 months after activation, you do a sleep study. And that's where we see what is really going on when you're using this device. And we can make adjustments while you're sleeping in that setting. This is just a general roadmap of it. I'm not going to go through everything, but the meeting the criteria, that sleep endoscopy, getting the insurance authorization and scheduling surgery, doing the surgery, activating it. So, and then sleep study. So it's a process, definitely a process. But this is just a general map of kind of how things would work. So does it actually work? It's a expensive implanted device. Is it actually worth it? So there's been a lot of studies here that do show that it works very well. The initial study that's kind of spurred the FDA approval was something called the STAR trial, Stimulation Therapy for Apnea Reduction. This was published in the New England Journal of Medicine in 2014. And it followed 126 patients who had the surgery. And all these patients were followed at 2, 6, and 12 months. At each one of those time periods, they actually had another sleep study. So it was pretty intense for these patients. And they also did some surveys. And so what they found was that before implantation, so baseline, patients had a median number of obstructive events of 29.3 obstructive events per hour. And at the 12-month mark, it was significantly decreased to only 9 events. The number of events where they actually had a decreased level of oxygen or oxygen levels, 25.4 down to 7.4 events where they decreased at least 4%. So also much improved. And then this is a survey. There's a survey called the Epworth Sleepiness Scale. So patients beforehand, so normal is 10. So the median before they went through the surgery, so they were above that threshold. They were very sleepy during the day. And then afterward, these patients significantly improved down to the normal range at 6. Another just interesting part of this study was that at the 12-month mark, they actually randomized. They took 46 patients. They randomized them into 2 groups, and then they said, one group, you guys keep using your Inspire. The other group, stop using it. So stop using it. And then at a certain period, a few weeks later, there was another sleep study that was done. And the patients so again, this is basically the baseline of the 2 groups. Basically similar. This is what happened after they all got implants. Again, we talked about that nice improvement. Now, if you split these 2 groups off and have one of them keep using the Inspire and the other one stop using it, and so there was still a sustained decrease and improvement in their sleep apnea for the people who kept using it. And those who had another sleep study, when it was turned off, I mean, their sleep apnea basically went back to what it was before. So we see that it seems that it was really working well using this device. Don't want to belabor too much research here, but there was another study. This was a 5-year follow-up, 5-year outcomes that demonstrated, excuse me, demonstrated that there was still robust response after 5 years. So the patients in this group, again, they started off with almost 30 obstructive events per hour. After Inspire, they were down to 6.2 after 5 years, representing about an 80% reduction in the number of obstructive events. Bed partner snoring. So there was a significant decrease in reported snoring. So 83% of patients snored loudly beforehand, and only 10, snored, in some way that was bothersome, representing an 88% reduction in snoring. And then finally, the last research study is something called the ADHERE study, similar to the other ones, but basically a number of patients completed 6 and 12-month follow-ups after getting the device. This is a little bit more recent, and showed similar results. So again, starting off at a really high number of obstructions, and then at the final visit, really being much improved, and that sleepiness index or score, and started off very high and very low. So all these studies keep corroborating this same data. Another interesting thing that we got from the ADHERE study is that patients seem to really like it. So so people 95% favorable. It's much better than CPAP. And would you recommend it to a friend or family? 96% said yes. 94% said that given the chance, I would do it again. And 93% were overall very satisfied with having the device. And people use it. In fact, there's some data that shows that they use it more per night than CPAP. So in this study, the patients use it for about 5.6 hours per night. In other CPAP studies, people are using CPAP for maybe 4.2 or even 3.5 hours per night. So people use it longer as well. What are some of the risks? So what are the risks of the procedure? So we can separate into two groups. There's procedure-related risks, and then there's also, we'll go back to device-related risks. So procedure-related, so every surgery has risks. It doesn't matter what surgery it is in the world, every surgery has a risk of infection or bleeding. For almost every surgery, these risks are very minimal, and that's a similar story for Inspire. Because we are manipulating the nerve of the tongue, so it's possible that there could be some temporary tongue weakness after the procedure. That was a somewhat common experience, but that resolves. Temporary incisional pain, I mean, it's surgery, so there's gonna be some pain. You might have a sore throat just from the breathing tube. As we're putting that breathing sensor in, just have to be careful not to go through the muscles of the chest, sort of toward where the lung is, and introduce air into the chest. That's called a pneumothorax. I mean, that's extremely rare, but that's also a reason why after the surgery, we do an X-ray in the post-op area, just to make sure there's no air around the lungs, no sign of this pneumothorax. And then every surgery has a risk of scars. So same with this, there's 2 incisions, there are 2 scars, but they heal very well. And then some of the device-related risks. So using the device, there might be some discomfort due to the electrical stimulation. There's a lot of things that we can titrate and change to try to make it more comfortable. People report sometimes they get a tongue abrasion. So just to go back, like how far is your tongue actually going out? It's not like going way out of your mouth, but it basically goes to the level of the teeth. It kind of hits the back of the teeth. And so for some people, just scraping against the teeth can cause maybe some tongue abrasion or some tongue discomfort. Again, we can change some of the parameters to help with that. Still might have some dry mouth with it. It's possible that you might need additional surgery to reposition or replace a part if there's something that doesn't seem to be working well. There was a study that showed 5% within 5, so it's a very low percentage of people needed to go back to the operating room for something like that. There could be a problem with the remote control. that can be dealt with and fixed. And then also visibility of the neurostimulator under the chest skin. So that really depends on the individual. So if you're like very, very thin and don't have much skin or muscle or fat here, yes, you're going to be able to see it, just like you'd be able to see like a pacemaker, and you'll see the outline of it. Other people who have some, a good amount of tissue there, you will not be able to see it. You'll feel it. You can feel it if you kind of press on it, but you won't be able to see it. So what about insurance coverage? So at this point, there's broad insurance coverage for Inspire surgery. A lot of private insurances cover it. Medicare covers it. A lot of VA hospitals will cover it. And the copays are basically based on what are the rules of your insurance. So very important to note, though, so this is probably very relevant to maybe a lot of people here or watching, is what about the Torrance Memorial IPA insurance? So it's a kind of work in progress. We're hopefully moving along and hopefully be able to kind of fully approve this in the near future. They're still reviewing the technology and the data. And so I think it really will depend. So even if you do have the Torrance Memorial IPA insurance, I think it's still worth coming in and being evaluated and going through the process, because if you meet all those criteria, then I think it makes it a lot easier to get a pre-authorization and kind of show there's an interest but I think in the near future, and this hopefully will be fully covered. So as a summary, if you tolerate CPAP, keep it. If it works for you, there's no reason really to seek any other treatment. So it's non-invasive. It can work extremely well for people. However, a lot of people don't tolerate CPAP very well. We talked about how sleep apnea is complicated. There's different levels of the throat that will cause sleep apnea. There are maybe a number of surgical options that can either make CPAP more tolerable or even cure sleep apnea. For example, nasal surgery. We talked about the throat surgeries. And really to figure out if you're a candidate for any of these things, come in and see an ENT for evaluation. Again, one size does not fit all with the surgery. Surgical success highly depends on your anatomy, your body weight. And then we touched upon the Inspire surgery. Again, this is a surgery that has a permanent implant. There are still criteria to meet, so not everybody is a candidate, but those indications are expanding. And in general, there's broad insurance coverage, but it's still a work in progress for some insurances. So that is all.
Before we go to the questions, did somebody lose their cholesterol test card? Anybody? All right.
Anybody need paper or writing implement?
All right, we'll start with the first question. If you snore, does that mean you have sleep apnea? Would Inspire help with snoring? Mic's not hot.
Still not working. Oh, there we go. Okay. All right. So snoring is different than sleep apnea. And actually, I always tell this to people that whenever someone comes in and say they have a problem with snoring, we always have to differentiate. Is it just plain snoring, or is there actual sleep apnea?
Mic's off.
Yeah. Okay. Right. So snoring again is that noise, that vibration of parts of the throat causing that really loud noise. But snoring on its own is not harmful at all. I mean, it'll be harmful to your marriage, but it's not harmful to your health. And so someone can snore away all they want, and nothing bad will ever happen. All right, sleep apnea is different. So sleep apnea means that there's actually something blocking the airway, and that can be harmful over time. So over time, that can make you more predisposed to various cardiovascular risks and risk of stroke and diabetes and heart disease and all that. So that really is a medical problem that should be treated. So just because you have snoring does not mean you have sleep apnea. Usually, people might have a suspicion that there's sleep apnea because not only will there be snoring, but there also will be that sort of snore, 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 then get really quiet, pause for a while, and then cough, choke, gasp. That's like we call that witnessed obstructive pauses. So that's more of a sign that there might be more going on than just snoring. And let's see the answer to the second part of the question. So yeah, Inspire will treat snoring. It does help snoring, but it's not indicated if snoring is the only problem. So there has to be sleep apnea as well.
I have a BiPAP machine. I stopped using it. I would wake up too bloated. What guidance can you give to reduce inhaling too much air while sleeping?
So the CPAPs and the BiPAPs usually have an upper limit to the amount of pressure it gives. And this pressure is not supposed to be more than the pressure that prevents air from going into the stomach. Now, in some people that might happen, particularly if you have like hiatal hernia or just a weak muscle between the esophagus and the stomach, and air would end up in the stomach. And for those people, we can adjust the pressure down. A BiPAP is a little bit different from a CPAP, where you have two levels of pressure, one when you're breathing in and one as you're breathing out. Sometimes the upper pressure when you're breathing in is higher than that pressure that prevents air from going into the stomach. And for that, we can adjust the pressure down so it doesn't go into the stomach and cause the bloating. You just remember that if you do adjust the pressure down, you may end up having a little bit more sleep apnea. And sometimes we just have to live with a balance between how much pressure you're giving and how much bloating is happening.
Thank you. Next question is, what is the cost of Inspire?
So I think the device the device itself is like between like 20 and 40, maybe the upper end like $40,000. It's a very expensive device, but with insurance coverage, I mean, it's covered. And again, it's according to the rules of your insurance. So like, you would have to know what your insurance benefit is. So like, for example, if you have insurance and it says your surgery is covered 100% after you meet a deductible, so the same rules will also apply to Inspire. If it's like 80% after deductible, so it really depends on the insurance. But once it's covered, the cost is going to be, I mean, similar to maybe many other big surgeries, I guess.
Thank you. Next question is, I have a lot of friends who swear by marijuana tincture, gummies, joints, etc. That's not my question. For help with sleep, and I'm wondering what your thoughts are about it.
So I guess my answer here is, if it works, why not? Sometimes these things work as a placebo. You check off that list that I took the gummy, I took the medicine, then I'm ready to go to sleep. The problem with these things is that even though they may be sedating in nature, they may disturb the quality of sleep to a certain extent. But as long as you feel well the next day and you're not tired and you're not sleepy, then there's probably no harm from that.
Next question, does the CPAP machine cure sleep apnea?
So sleep apnea is a chronic condition. Think of hypertension, for example. Every morning or every day, you would take a pill for your blood pressure to control it. if you stop taking your blood pressure medicine, then your blood pressure will go back up again. So CPAP is the same for sleep apnea. As long as you're using your CPAP machine, your sleep apnea is being treated, but it's not being cured. So if you stop using your CPAP machine, you will have sleep apnea that night. So it's more of a treatment than a cure.
Why am I waking up between 1 a.m. and 3 a.m. almost nightly? I've read this is the optimal time for your liver to dump toxins from the day. I eat clean, exercise, do not eat sugar or drink alcohol, and I'm very careful about anything that can convert to insulin. So why do I still wake up?
So this is a very common problem. And if you notice how the question is placed is that you wake up at the same time every night. So as I mentioned in my talk, there is an internal clock. And just like an alarm clock, you can set that clock to wake up at a certain time every night. And usually what happens is you wake up at one point and you look at the clock, it's 1 a.m. and you're somewhat annoyed by that. And then the next night you wake up and it happens to be 1 a.m. and you're more annoyed. And then a few nights in a row, you've set yourself up to wake up every night. It's almost like you're setting an alarm clock in your brain to wake you up. And then every time that happens, you become more frustrated and more frustrated. Now, the second part of that statement, you notice that the person said that he knows the time. And that is what we mean by clock watching at night is you wake up and the first thing you do is you look at the clock. And that in itself becomes a habit. If you remember the graph that I put up there, that's one of those habits that we develop to make us cope with the insomnia that we're having. So this is part of the insomnia, the chronic insomnia. So insomnia is either having a difficult time falling asleep or a difficult time staying asleep. So that is the staying asleep portion of it.
Next question, is there an optimal time to take mineral supplements? Can taking supplements at night cause you to wake up during the night?
I don't think that there's an optimal time for that. Taking the supplements will probably not affect your sleep unless you take them with like a lot of water and then you have to wake up to go to the bathroom, but in themselves, they should be okay.
Can you talk about gut health and how it impacts your sleep? Gut health.
Oh boy, this is a difficult one. I'll probably have to look that up for you.
Okay. You got a lot of questions. How much is too much sleeping, such as napping? Are there better sleep postures?
So the first part of the question, how much is or is too much? Well, we don't really know why we need to sleep, and we know why we need to sleep. So we need to sleep to feel well the next day. But really, why do we do that? And nobody really knows the answer to that. So when you look at the reason we sleep is so we function well. So as far as timing goes, I'd say that the amount of sleep that you need is the amount that makes you function well the next day. Now there's an average number. The average number is somewhere between 7 to 8 hours every night, but that's an average value. And to get that average number, you have people who sleep much more and people who sleep much less. So I have people in my office who need up to 9 or 10 hours a night, and I have people who only sleep 3 or 4 hours a night. As long as you're able to function well the next day, that is the appropriate hours that you need to sleep.
Next question, does a patient need to see a pulmonologist first to be referred to a sleep specialist?
Not necessarily, but most sleep specialists are pulmonologists. Well, let me take that back. Sleep specialists you have sleep specialists who are pulmonologists, who are dentists, who are ENT surgeons, who are neurologists, but a large number are pulmonologists. So if you end up happening to see a pulmonologist who happens to be a sleep doctor at the same time, then it's just, you're there, but no, you can go straight to a sleep specialist without passing by a pulmonologist.
Next question, how do you decide on the sleep apnea device or the mouth/teeth guard?
So as I mentioned a second ago, there are many physicians who treat sleep apnea. So pulmonologists like myself do so. ENT surgeons treat sleep apnea. Dentists treat sleep apnea. So frequently, the type of treatment that you are offered or told about usually depends on whose office you're sitting in. So if I were a dentist, I would be talking to you about getting a dental device. If I were a surgeon, I'd have you on the table before you leave the office. But I'm a pulmonologist. So, but in reality, like Dr. Gertel said in his talk, the gold standard is still a CPAP, and there are criteria that we follow. So, the severe sleep apnea, we generally talk about using a CPAP machine. For the mild to moderate, we have a long discussion about the pros and cons of both options. And then for people who are just intolerant to a dental device or a CPAP machine, then we refer to our surgical colleagues.
Yeah, I mean, just because I'm a surgeon, I'm not jumping right to surgery. I mean, I love doing surgery, but I hate doing surgery for the wrong reasons. So, yeah, there are a lot of patients that come through my office also who have never been diagnosed with sleep apnea. They're actually coming because they're snoring or they're concerned for sleep apnea. They haven't seen like a sleep medicine specialist, and I might be their sort of first point of contact to evaluate for sleep apnea. So I do order a lot of sleep studies myself. I do prescribe CPAP machines. I do suggest maybe try see a dentist and get a mouth guard. So there's a lot of avenues into figuring out, do you have sleep apnea, and kind of what might be the best treatment. Some people's primary doctors may also be comfortable with that type of thing. So we're not necessarily specifically saying, well, surgery. If you come to me, you're going to get surgery. If you come to Dr. Eltawil, you're getting a CPAP machine. It's not that simple. We're trained sort of to we're trained to really to treat sleep apnea in all different ways.
I have severe snoring and used a pulse ox to measure my oxygen levels. It never went below 90. Can I be assured I only have severe snoring, or is it possible I have sleep apnea?
Really, the only way to ensure that you don't have sleep apnea or to rule it in or out is to have a sleep study. So just like a simple oxygen monitor on your finger is not going to give us enough information to be able to make that determination. So if you snore loudly, again, when people tell me they snore loudly, I say we have to figure out, is this just snoring or is there actually something more to this? And so usually we'll order a sleep study to see what's going on.
Can you talk about medical problems sleep apnea causes?
So I think one of the biggest issues that sleep apnea causes is daytime hypersomnolence, and you're feeling sleepy. In fact, one of the most common causes of car accidents is drowsy driving, and sleep apnea is a big contributor to that. Sleep apnea has been known to has been associated definitely with increased blood pressure, and it is documented as one of the causes of high blood pressure. We know it puts you at risk for other cardiovascular events. It puts you at risk for having heart attacks, heart failure, arrhythmias, puts you at risk for having strokes. And it also makes controlling your sugars harder. So if you're diabetic, you have a harder time controlling your blood sugar. It's difficult when you have sleep apnea. You're not sleeping well, and there's a big relationship between sleep deprivation, which sleep apnea causes, and obesity or difficulty losing weight. There was a study a number of years ago that looked at people who died in a certain year and looked at what they died of, and particularly looking at people who died from cardiac complications or heart complications, and they found that the majority of people died between 8 a.m. and noon. And the exception to that were people who had sleep apnea. They died between midnight and 6 from a heart-related problem, and 6 a.m. So the biggest problem that we see with sleep apnea is the relationship with high blood pressure and heart, but then there are all the other things that I mentioned as well.
Will a dental device give you an underbite?
So I think the biggest concern with dental devices is just some of the different stresses and pressures it would put on the jaw joint or the TMJ joint. So over time, it's possible that it can alter some of your dentition and the way that your teeth come together. It could potentially give you some soreness in your jaw, so it's actually painful to chew during the day and sort of TMJ like symptoms. But I think to permanently alter, it's usually not that extreme, and certainly you probably stop using it before you could get to that point.
And yeah, that's all true. And also many dentists end up giving you a device to use after you wake up in the morning to realign the teeth and put the jaw back in place.
What is the ideal amount of sleep? 8 hours, question mark. What if you don't get 8 hours of REM sleep?
So I just answered that question. So the right amount is the amount that makes you feel well the next day. And the average is 7 to 8 hours, but that's an average number. Some people need more, some people need less.
Does everyone who snores have sleep apnea?
I think we answered that question,
Yeah.
so let's move to the next one.
Does Inspire work even with a large tongue and high BMI?
So yeah, Inspire can work even with a large tongue. So high BMI, so it really depends. The success rate for people, the higher BMI there is, then the less success there will be. And that's why there are limits as part of the criteria. And so they are expanding because we have been learning over the years that Inspire can help people with higher body weights. But at the same time, the higher it is, maybe the less successful it would be.
Once you have sleep apnea, will you always have it, or can it be cured with proper diet, etc.?
So sleep apnea is a chronic condition, and it will be present every night as long as that anatomy of the airway stays as it is. So Dr. Gertel showed the pictures of the anatomy of the airways and all the things that can cause the blockage. It is not one specific place in the airway that causes that blockage, but it's somewhere around that in that airway causing it. So unless something changes that anatomy, the sleep apnea will be there all the time. So Dr. Gertel also mentioned how we gain a little bit of weight and then all this soft tissue flops back when you don't have a lot of muscle tone when you're sleeping, and it just blocks the airways. Well, if you do lose weight, you lose a lot of that soft tissue. So it is possible that sleep apnea will get better with weight loss. If the tonsils are large and they are the cause of the sleep apnea, if you remove them, then your sleep apnea will go away. But unless there is a change to this anatomy in your airway, sleep apnea will always be there.
Does the patient have to fail CPAP before qualifying for Inspire?
Yes, I mean, generally, you do have to try CPAP first it could even be just a short period of time, but you really have to demonstrate that you've tried and then failed for whatever reason it is. Again, it's a very broad definition of intolerance to CPAP, because right now the way Inspire has been approved or cleared is that it's really sort of second line, or it's really indicated for people who have failed CPAP. So you really do have to first try that CPAP first, and then you might not be with it for a very long time, but it is an indication right now.
What are the risks of Inspire implantation? Does the wire ever come off?
Yeah, I mean, I think we went through a number of the risks in the presentation, but as far as the wire come off, yeah, it's possible. It's a very low risk, but it is possible that the wires get displaced in some way. And if that happens, then we would have to replace that, and that could potentially be another surgery to take care of that.
What is the treatment for long-term insomnia?
So that's a very long subject. We talked about most of the treatments for long-term insomnia in the presentation. It differs from person to person to person. So what we would have to do is you would have to come to the office, we'd sit down together, have a chat about what could be causing it, try to identify the stressor that causes sleep apnea. There's a bunch of medications out there we discussed that could be used. Other maneuvers like cognitive behavioral therapy and relaxation, mindfulness, and so forth that could be used to address the sleep apnea. We try to adjust your sleep hygiene. So all the things that we mentioned in the presentation.
All right, we got time for one more question. Severe cramps at night and in the day, wakes me up at night. What do I need to do? Legs, arch of foot, calf.
So I mentioned in my presentation about restless legs, which are specific to sleep, and they happen only when you're ready to go to sleep at night. If the cramps are happening during the daytime and during the nighttime as well, and they're disturbing your sleep, this is usually not the restless leg syndrome or the leg movements that happen at night. This is different. This could be a muscular issue, it could be a bone issue, it could be a nerve issue. So you would have to come to the office and we try to figure out what is causing these cramps and figure how to treat that. Sometimes it's electrolyte abnormalities, sometimes it's a vascular problem, sometimes it's a joint problem. So this differs from person to person.
All right, looking at the clock, it's 8:02. We're going to close this presentation. Thank you for coming, and we'll see you at the next conference, okay?